Welcome, my name's Oliver Allenby Smith. I'm a general surgeon here at Poole Hospital and the Harbour Hospital. I've actually decided today to talk on something that's a very common condition that I'm sure a lot in the community and a lot of people in hospital will see, and that's gallstone disease. I expect most people feel they know the majority of what there is to know about gallstone disease, but I think actually we can always learn, and so I've called this a gallstone refresher, just to run through a few of the common presentations and things. So if we can start by talking about gallbladder stones, and actually I realise as I start to think about these talks that for us we try to be very clear on whether it's gallstones within the gallbladder causing trouble or the bile duct. And at initial presentation sometimes this gets blurred, but it is crucial both to the way they're managed in the community, when you refer them in, and also how we manage the patient in hospital. So starting with gallbladder stones, they can present in a number of ways. The first one that we see is actually asymptomatic stones, often seen on scans, and you'll be aware that if they've got a normal common bile duct, those can be reassured and no further investigations are needed. The next group that's seen very frequently in the community is those with biliary colic. So essentially we're talking about stones within the gallbladder, causing the gallbladder to contract and causing the typical epigastric or right upper quadrant pain. The pain is often in the evening and tends to be worse after food. So with these patients the best bet is a routine referral if the pain is manageable in the community, and that can either be to the local NHS hospital, or here we do offer a one-stop service of ultrasound and consultation. Then the last group of gallbladder stone presentations really is acute cholecystitis. And so again, very similar to biliary colic, but typically symptoms may have lasted longer, and most importantly is often associated with a degree of sepsis. These patients again can often be managed in the community, sometimes with some antibiotics, but if they're unwell then they need to consider emergency admission. So then we move on to bile duct stones. And again, we can start with asymptomatic bile duct stones, but the management is quite different actually, and if we find bile duct stones on any other imaging, then the current recommendation is actually for clearance of those stones, because they can cause a variety of dangerous conditions, obviously pancreatitis and cholangitis in the future. Then we move on to painless jaundice, classically thought of as being a malignant cause, but actually quite often can still be gallstone disease. They warrant, as you'll appreciate, very urgent referral, but can often be managed as an outpatient with a fast-track referral. The things particularly to look for with them is there any signs of sepsis or also signs of renal failure, so we have to encourage them to drink plenty of fluid. And the next condition related to bile duct stones is cholangitis. In these patients they typically have pain, fever, and quite often jaundiced as well, or abnormal liver function tests. We have to be particularly careful with these patients. They can deteriorate very rapidly and become unwell, so I'd recommend urgent emergency admission for patients who we believe may have cholangitis. The last group is also a familiar one, acute pancreatitis. Often that's actually a diagnosis that's made in hospital because we base it on the serum amylase being at 3 times the upper limit of normal, and so that's often not available in the community at the time of presentation. So next I'd like to show a slide. This is actually a flowchart that's been taken from the new commissioning guide produced by the Association of Upper GI Surgeons, and it's currently out for consultation, but I expect it won't change a huge amount. And it actually has followed the same pattern as I've just described, which is trying to work out early on whether these patients have bile duct stones or gallbladder stones, and then applying treatment dependent on that. So at the top, patients are essentially split into whether there's signs of cholecystitis, pancreatitis, cholangitis, essentially sepsis and pain, and those they recommend emergency admission. And then it separates out as to whether their liver function tests are abnormal or whether they have jaundice. And again, if they're jaundice, then they need urgent but not necessarily emergency admission. And then it goes on to the management of the gallbladder stones without sepsis or jaundice. And it does comment at the bottom that it's worth trying a low-fat diet. Around 30% of patients will show a strong improvement in their symptoms with a low-fat diet. So the range of investigations we now have for gallstone conditions has expanded over the years. I thought I'd run through what we currently use. So ultrasound and liver function testing is available in the community and is still the best investigations to start with. It particularly helps us identify gallbladder stones, and in fact generally ultrasound is considered still the gold standard for this. We've then got a range of other investigations that include MRCP, which is essentially just an MRI scan of the bile ducts, or endoscopic ultrasound, which is far more invasive and involves a patient passing a gastroscope with an ultrasound probe on the end. Both of those give far more detailed images of the biliary tree. You'll also be aware that we use CT, and we tend to use that predominantly for looking at the actual parenchyma of the pancreas and the liver rather than the ducts themselves. And then ERCP used to be a diagnostic procedure. It's now purely kept as a therapeutic procedure, and so once again it's quite invasive, and although they're very rare risks, there are significant risks associated with it. So we'll tend to image patients with the other tests and then treat bile duct conditions with ERCP. So management stones, we split into the gallbladder stones initially. Low-fat diet, as we discussed, may control symptoms in some patients, but really the main treatment is laparoscopic cholecystectomy. It's worth mentioning that there are now 60,000 procedures performed a year, and actually a threefold variation in different regions, different CCGs. The surgery should be performed, NICE now say, by surgeons that perform the surgery regularly. The risks and things have come down dramatically with cholecystectomies, but essentially because of people performing high volumes. And that means that conversion rates are now less than 1%, and major complications are very rare. The last thing to say is you will have patients looking on the internet and coming along with ideas of drinking a litre of olive oil and various other concoctions, and it's just to say there's no evidence behind any of those, and we no longer dissolve or break up gallbladder stones, so the treatments are purely conservative or surgery. This is to reassure anyone that's involved in commissioning. This is a Dorset CCG, and you'll see that we perform a completely average number of cholecystectomies locally. And then, so bile duct stones, as I say, we manage them very differently. Personally, my preference is for ERCP as the mainline treatment, and this is performed as a day case endoscopic procedure. There are other options such as laparoscopic bile duct exploration, which we can also perform. The benefits of this are that they can be done at the same time as cholecystectomy, but the downsides are that it's very unpredictable, so patients come in expecting a gallbladder operation but can end up having a considerably longer operation. So I prefer to go for ERCP in advance. Then we've also have PTC, which is essentially radiological access to the bile ducts. This is not used very much in gallstone disease, but it's just starting to creep in as an option when we're struggling with ERCP or surgical options. Okay, so in 2014, NICE brought out some guidelines on managing gallstone disease, and the first few were pretty much as expected. I just highlight the last one, which is a very important change from our point of view, and this was essentially suggesting that cholecystectomy should be done acutely within 1 week of their diagnosis in hospital, particularly for patients with acute cholecystitis. And this comes off a sort of build-up of evidence over the years that shows that if you actually treat gallstone disease a little bit like appendicitis, and they come into hospital, have scans, either taken straight to theatre, then the outcomes can actually be very good. Patients can go home the day after their surgery and they can recover very rapidly. The difficulty and the problem with it is actually largely providing the treatment. It's very difficult for hospitals to have the expertise available every day of the week to provide this kind of service. And if the cases are delayed by a few days too far, then it becomes, the benefits disappear, and after a few days they're better off being treated as an elective operation. And so currently very few hospitals offer this service, and certainly none locally. A couple of questions that GPs often ask. The first one is about classic sounding biliary symptoms but with no scans on, no stones on an ultrasound scan, and this is actually quite a fairly common condition for us to see, and we now know that some people with dysfunctional gallbladders will actually benefit from cholecystectomy, and studies have been done showing that if we do nuclear medicine tests showing that the gallbladder is not functioning normally, then maybe 70% of patients will benefit from surgery. So if it does sound like classic biliary colic, even if there are no stones on the scan, it is worth us seeing them and discussing it with them. Generally, I'll ask our gastroenterology colleagues to see the patients as well to ensure we're not missing anything else. The other area that we commonly get asked about is gallbladder polyps, often picked up on ultrasound and often asymptomatic, in which case you'll see on the slide a bit of guidance as to how we manage them. Essentially between 5 and 10 millimetres they can be managed with repeat scans in the community, but above 10 millimetres we'd recommend cholecystectomy.